Thank you all so much for this wonderful invitation. I've attended a couple of your presentations because I just wanted to see what you're up to, and it's very cool what you're doing. And I also want to make sure to say to all of you, as soon as yes, happy St. Patrick's Day. So if you're serving green beer and soda bread, send some my way. Just for background, I grew up in Fort Lauderdale, but I reverse immigrated to Rochester, New York. This is my house only a month ago or so. My husband was finishing his MedPeds residency at the University of Rochester so I thought I would be here briefly. And that was 1980. So you can see what can happen. I spent my career, as I said, at the University of Rochester, and that continuity and the culture here, I think, is part of what's facilitated my own leadership development. Before we get to that, I just want to express my affection so much for a lot that is Texas: the food, the music, the many cultures, the people, the landscape. I went to Duke to college and then to graduate school at UNC, but I ended up doing my psychology internship at UTMB in Galveston and my postdoctoral fellowship in family therapy at the Texas Research Institute for Mental Sciences in Houston. So I'm pretty sure I'm probably the only person in Rochester with both red and yellow flowered cowboy boots and summer and winter cowboy hats. So thanks for welcoming me back. I have to say that my heart sank as I watched what happened with the storm in Texas. So speaking of crisis leadership, I hope that things are improving there. I want to focus tonight on leadership development during a time of uncertainty. The pandemic has certainly been both stressful and an opportunity for us to explore some principles of leadership that I hope you'll find useful regardless of your role. Even over Zoom tonight, I can feel your energy, that feeling of we're all in this, whatever it is, together. The pandemic has simultaneously brought us together and isolated us at the same time. These kind of contradictions or paradoxes can create both frustration and be an opportunity for innovation. Certainly, this pandemic experience is a step up to the plate kind of situation. As one of my heroes, Jane Goodall, said recently, I've come to realize through my life there really aren't coincidences. They're opportunities, whether you take them or not. Each of us has important ideas and skills to contribute to this situation, as there really is no one who's expert at dealing with all the biopsychosocial features of what we're experiencing. So it's all hands on deck at the beginning and middle of this challenge. So I hope sharing some of my experiences prompts associations to yours. We already talked about my various roles right now, but to say that University of Rochester is known as the home of internist George Engel, the father of the biopsychosocial approach, and Lyman Wynn, one of the founders of family therapy. At the Institute for the Family, we think systemically with faculty and fellows integrating behavioral health into 9 clinical departments. These psychologists see patients, provide communication coaching, teach psychosocial medicine, and collaborate with other healthcare professionals. Later, I'll describe how, in the early days of COVID, we pivoted quickly to provide supportive services across the medical center. I want to share with you tonight my involving thoughts about leadership across the phases of the pandemic, from my pre-pandemic principles to the terror of the spring crisis, the summer letdown, including recognition of the twin evils of racism and inequity, the winter return of COVID, the New Year's vaccine excitement, the pandemic of loneliness and the need for psychological hibernation, our cautious belief that the end is in sight and that it's a time to maintain reasonable hope and promote resilience. I know it's hard to think about pre-pandemic now, but let's try. Directing the physician communication coaching program over the past 10 years, I've given considerable thought about how to train effective leaders. First, it's very important, especially now, to clarify your own mission. Write a personal mission statement, as it's that mission and the drive to achieve it that will sustain you. then be intentional. That is, be deliberate, conscious, and purposeful in pursuing that mission. The foundational skills of this intentional leadership are clear and positive communication about mission and vision, mindfulness and self-awareness, the ability to recognize when anxiety is driving interactions or decisions, self-regulation, listening to people of all perspective without giving into shortcuts that are projections or stereotypes, being willing to be influenced and changed by others, publicly rewarding others' work, and perhaps most importantly, standing behind what you believe to be true and best. So in times of chaos, pressure, and rapid change especially, intentional leadership means aligning and articulating our values and vision with our actions, measuring outcomes, and reshaping our approach when an outcome is misaligned with our intent. It means being accountable and moving up the ladder from being unconscious and blaming others to acknowledging reality, owning it, and finding solutions to complex issues. Intentional leadership attends carefully to organizational culture, diversity, and inclusion. One last point, the difference between good enough and great leadership is having the courage and commitment to stay the course when that's what's needed and staying true to your mission no matter how difficult. I really think persistence is an underappreciated skill of great leadership. So all that was before the pandemic. Let's turn now to leadership during the pandemic. My first pandemic leadership learning was that our pace of change during the initial crisis phase was mind-boggling, full of activation and adrenaline. No question the best leaders need to adapt to unforeseen challenges quickly. Then it turned out a pandemic pace can result in astonishing accomplishments. Telehealth was one of them. Vaccine development was another. But this fast pace has its downsides as well. Leaders made one set of decisions that fit today's data only to reverse them tomorrow because all the aspects weren't known or considered. Often the balance between hierarchy and collaboration was lost. Too much command and control, not enough collaboration. While mistakes are understandable, these shifts can make everyone else either confused, angry, or disoriented. So it's worth taking a breath. When making important decisions, think about who will be affected and which stakeholders need to be involved. When possible, collaborative decisions can ultimately save time. We need to ask, like Chinese philosopher Lao Tzu, do you have the patience to wait until your mud settles and the water is clear? Besides being confusing and contradictory, the pace of change was and still is exhausting. Deciphering ever-changing communication is exhausting. Zoom is exhausting. I spend 7 to 9 hours many days on Zoom, and recently I just hit the wall. In the middle of a Zoom clinical team meeting, I abruptly fell asleep with my camera on. I didn't wake up until I heard the secretary saying, Susan, the meeting's over. I was really mortified, but also amazed that it hadn't happened earlier. As health professionals, we know what the studies say about how to manage stress, the importance of healthy eating, exercise, social support, getting enough sleep at night. I know we must start with ourselves and then apply these same principles to patients, colleagues, and trainees. The pandemic caused us all to evaluate our situations to see what's needed and do whatever we can to help. I'll share with you some of what I and my colleagues did and invite you to think through it and appreciate all you've done. The psychologist on the wheel I shared came together early to share ideas about how to support our colleagues on the front lines, provide prevention and early intervention for them and our patients. Some of these activities are ongoing, some periodic. They include weekly Zoom check-ins for physicians, leadership, and staff, emphasizing strengths as participants share experiences, feelings, and suggestions with each other. One intense week last spring had 70 people from the emergency department on one check-in. Buddy systems. Some departments like surgery, paired up during COVID surges so that senior faculty touched base daily with junior faculty, senior residents with junior residents. Our usual self-awareness and support groups for residents increased from monthly to weekly. We established a new helpline for all employees and their family members for any physical, social, or mental health problem. One of our psychologists trained and supported the 70+ volunteers that staffed the line. All departments have periodic wellness surveys of every employee to assess climate and procedures and guide our interventions. I also worked on an ongoing national survey of primary care clinicians, including behavioral health, about their responses to COVID. Becca Etz, the director of the survey, asked for help because her team was disturbed by the level of distress expressed by many of these physicians. Here are a few comments from primary care physicians over the last year. The walls are closing in. We're surrounded by COVID. Help us. We're exhausted and stressed, taking care of patients first and then worrying about our own families. We've lost a third of our primary care workforce. One of our receptionists in her late 40s, married, 4 children, died of COVID in the line of fire. I've suspended personal income to preserve my practice. We're in a mental health disaster. I've had more patients die of suicide and overdose than COVID. It's beyond heartbreaking, and some of these are kids. This has been the worst year of my professional career. I will likely quit medicine as a result of this experience. Psychologist Nancy Ruddy and I review each survey's comments for themes, and then we write a brief psychoeducational response to go out with summary results that are sent to the participants. For example, we suggested focusing on small wins, accepting limitations, and doing what brought you joy in the past. Then we provide links to resources. Recently, we've started debriefing the research team to help with their secondary PTSD from analyzing these results. As you might expect, the physician communication coaching program has been very busy. It turns out that people aren't always their best selves when they're under stress. Communication coaching works to develop a culture of feedback to enhance self-awareness and provide booster shots of self-regulation. Regarding feedback, I regularly share Socrates' mantra, is it honest? Is it kind? Is it necessary? Just stopping to answer those questions before speaking would take care of so many problems. In addition, clinicians need help with difficult conversations about ethics, teamwork, and speaking with families about issues such as end of life and shortages of staff. And we make referrals to support their own mental health. Other key principles include not taking it personally when others disagree with us and being accountable rather than blaming others. I've given out more than one copy of a favorite book. Mistakes were made, but not by me. Intentional leaders use mistakes as an opportunity for self-reflection and accountability to reshape our own behavior and that of our organization. In addition to problems with self-awareness and self-regulation, we know that during a crisis with individuals, families, and organizations, boundaries can become blurry, responsibilities unclear, and roles confusing, what sociologist Sandra Petronio calls boundary turbulence. Certainly, we see this all around us during COVID. In each new phase, we need to intentionally re-examine roles and responsibilities in order to return to what should continue from before and redefine what needs to change. Then there are the written communications, emails, memos, and talks from leaders about decisions related to COVID. So I edit them to be simple and clear with short declarative sentences. I zoom in to provide feedback on meeting hygiene and difficult faculty discussions. We know leaders' communications can calm people's concerns or make them more anxious. It's all in how things are framed. What I say to leaders, and I try to demonstrate myself, is speak to a future of hope. Take the long view, promote resilience, and listen more than talk, especially to you, our early career professionals who have the fresh eyes and new ideas that we need. Finally, over-communicate. It's amazing how many times we need to hear a rule or suggestion before it sinks in. We also put out a weekly email to all employees in family medicine called A Breath of Fresh Air, or BAFA as it's come to be known, full of brief, inspiring stories, beautiful photos, and poetry by faculty and trainees, Zoom choirs and music, cartoons, and mindfulness reminders, anything to lift our spirits. Here's a photo from an August BAFA by family physician Deborah Pierce. Deb caught a rainbow one Sunday at Turning Point Park, which we took as a sign of good things to come, though it took a little longer than we'd hoped. Another challenge for leaders, work-life balance. The family structure of many health professionals has been upended at the very same time that COVID demands so much professionally. Like many of you trying to work and homeschool your children at the same time, an impossible task. Many families didn't live in their usual constellations. Some split apart by COVID, others, like mine, suddenly living together. Both our daughters live 6 hours away in New York City. When New York shut down a year ago in early March, their families came to our place in Rochester. It was shocking for all of us suddenly to be living together again. We had 6 adults working out of our home, along with a delightful 3-year-old and then her new brother. Here are my husband, my granddaughter, and me back in April, and our granddaughter and new grandson in early July. They were the silver lining of the early difficult pandemic phase, no question. But even when positive, restructuring family roles and routines takes a lot of energy. Thank goodness we didn't downsize. What to do as a leader with these profound changes and the lack of separation between work and family life. Without a national policy that provides much more family leave, job security, and childcare, it's very difficult to do more than be understanding, flexible, expect fatigue, and work to extend promotion dates. Another taxing part of this experience in our personal and professional lives has been the constant need for risk assessment. This has always been part of being a leader, but the pandemic brought a new level of uncertainty with multiple decisions about risk. Once we had the summer letdown, there were questions in our personal life, such as, should we go to a restaurant that has socially distanced dining or stay home for the 120th night in a row? How large should our bubble be, and does it extend outside of our home? At work, leaders had to face risk calculations such as, can medical students or psychology fellows see inpatients alongside residents if they have appropriate PPE? What if they have underlying conditions? Do we cut salaries or retirement benefits to deal with budget shortfalls? It brings to mind the sign on Obama's desk during the Affordable Care Act, hard things are hard. Apparently the new director of the CDC, Rochelle Walensky, has this sign on her desk too, so I guess it's just so. Summer also brought the awful killing of George Floyd and too many others, with a clear recognition of the pandemic of racism in our country. There were intense anti-racist protests and an urgency in our academic health centers about addressing inequities with patients, trainees, staff, and faculty. We had white coats for Black Lives demonstrations outside our family medicine clinic and at the hospital. By fall, each department had to submit our anti-racism plans to the dean. We continue working now with consultants on ourselves and our policies, and we have a long way to go. Amidst all this, winter brought the bleak second surge. On the upside, we felt like this time we know what to do medically, but for many of us, the second surge was brutal. More stress, more loss, more ongoing certainty, and another intense lockdown. There was, of course, the election, and then late December and January brought vaccine excitement. The atmosphere at our vaccination sites was like being at a carnival. People were practically giddy. We were all so happy. But then we also had to face the vaccine hesitancy felt by so many people of color based on historical racism in medicine. Our nation now seems to be fully awake to the relational and social determinants of health, gender, race, culture, and class. We need to expose those inequities and create change. At the U of R, before the pandemic, we had a sexual harassment scandal in the liberal arts college. We wondered about the problem in our own department in family medicine, so we conducted a qualitative study of faculty and residents asking about experiences with gender bias and sexual harassment. One paper about that study is now in press in the journal Family Medicine, and the other one is under review. The results are both not surprising and very distressing. It's been useful in so many ways, including we now have scenarios for role-playing and consensus building about what's okay and what isn't, how to report the incidents, and how to be an effective ally when witnessing sexist or racist behavior. One of the great privileges of leadership, which I was fortunate to have when I was president of the American Psychological Association in 2016, is having the opportunity to meet extraordinary people. For example, I had the honor of speaking personally with Congressman John Lewis a few times. Here are some words of inspiration and aspiration from his 2012 memoir. Choose confrontation wisely, but when it's your time, don't be afraid to stand up, and speak out against injustice. And if you follow your truth down the road to peace and the affirmation of love, then we'll find a nation, a world community, and a beloved community that's finally at peace with itself. In addition to ongoing racial and political unrest, by this January, we had a pandemic of loneliness and a sense of loss that was by then normative. Psychologist Eileen Russell wrote a blog in mid-February called Psychological Hibernation and Resilience. There's a season for everything. As the owner of Fred, the cute turtle you see at the top who hibernates each winter, this concept was appealing to me. Russell said, for a few weeks, I've been noticing that many of my patients seem to have entered a new state. It isn't quite depression, though it sometimes seems like that. A number of people have shared feeling bored and restless at the very same time. It's like this New Yorker cartoon. The girl's saying, did I tell you about the really big pigeon I saw? I did? Sorry, I ran out of new things to talk about a few months ago. Russell described this time. It's as if the color has been drained from everything, but all remains recognizable, making the experience somewhat confusing and disorienting. It's an amorphous, eerie, threatening, and isolating time. The current light at the end of the tunnel phenomenon may not initially inject us with hope and relief, but rather, or perhaps also, wake us up to the reality of what a slog this has been. We're not looking too far in the future, we're just dealing. To my mind, resilience is not about being strong in the sense of being unaffected. Increasingly, I think it's truly about flexibility. If we let go of the unrealistic expectation that we could be feeling so much better if only we fill in the blank, might we experience this midwinter period of our lives as slightly more bearable and circumscribed? If there's a season for everything, perhaps this time invites us to rest and let go of our need to turn reality into what it's not. If we allow for a certain psychological hibernation now, we might trust ourselves to welcome spring when it comes, because it will come. And now, is spring at our doorstep? Most of us are vaccinated, but we have a few months before that's universal. And the mental health surge has begun to roar. Even Fauci's concerned about that. Still, we're cautiously hopeful that the end is in sight. Some people respond by partying prematurely. Others are vaccinated but remain fearful of going outside. And the importance of population health, prevention, and intentional leadership remains. I think this time requires what psychologist Cato Weingarten calls reasonable hope, a concept she applies to healthcare prognoses, but seems as applicable to our current state. As opposed to hope alone, reasonable hope suggests something both sensible and moderate, directing our attention to what is within reach. It refers to actions one takes rather than feelings of hope one may or may not be able to summon. I'll finish up with the 5 characteristics of reasonable hope. They are relational. It can be likened to the African concept of Ubuntu, which Desmond Tutu described as being enveloped in the community of other human beings, caught up in the bundle of life. Something to be practiced. It's a verb more than a noun, something we practice in the here and now, not something we passively wish for in the future. Sees the future as uncertain and influenceable. An uncertain future creates space for change, growth, and transformation, opening the door for possibilities beyond our current expectations. Seeks goals and pathways. Reasonable hope looks for what goals can be accomplished now and adjusts as new possibilities and pathways become available. Accommodates doubt, contradictions, and despair. Reasonable hope can hold the whole of our lives with all of its losses, joys, setbacks, and surprises. Instead of closing our eyes and making a wish, we can open our eyes wider and turn toward a light that may not yet be born. In the meantime, our central tasks as faculty leaders are to set realistic expectations, promote resilience, and maintain reasonable hope. We will trust ourselves to welcome spring as reasonable hope says it's almost here. Thank you.